Live now, ma'am. Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect. Welcoming you all for today's webinar organized by Andhra Pradesh, Tamil Nadu, Madhya Pradesh, Odisha, and Maharashtra OBGYN societies. So it's my privilege to introduce the conveners of today's webinar, Dr. V. Radha Lakshmi ma'am. Ma'am is professor in OBGY and also professor in Department of OBGY in SRMC Nandyal, Secretary of Kurnool OBGYN Society Foxy. Ma'am is the Journal Coordinator of NTRUHS AP, in charge of Mission Pink Health IMA Kurnool. Ma'am has teaching experience of 30 years and ma'am has conducted regular full-day CMEs with credit hours. Ma'am is the chairperson and speaker in national and international, national and state level conference. I welcome you, ma'am. It's my privilege to introduce Dr. Umayal Murugeshan, ma'am. Ma'am is the Managing Director of Sri Kumaran A Specialty Hospital in Tambaram, President of Kanchipuram OBGYN Society, Organizing Secretary of SZVP Conference 2024, past President of IMA Tambaram, Chairperson of Women's Wing IMA TN State Branch 24 and 25. I welcome you, ma'am. And it's my privilege to introduce Dr. Sujit
No, I'll introduce
Yes,
Sahiti.
yes. I welcome you, ma'am, and I hand it to you, ma'am.
So it is my privilege to introduce Sujit. Sujit did his MD from GMC Aurangabad, USG training in Bimal Sahani Sono Scan Center, basic invasive procedure training in Kurana Sas Apex Institute of Fetal and Reproductive Sciences, FMF certified for 11 to 13 week scan, Vice President Society of Fetal Medicine, Marathwada chapter, past chairperson Fetal Medicine Committee, amongst member ISWAG, and director Shri Hospital, interested in advanced fetal ultrasound and fetal interventions. Now I request to put the CV of PC sir. PC sir will join in 2 minutes. Sir is a senior obstetrician and gynecologist. So we know all about him as the president of Foxy 2011. And he is the senior obstetrician gynecologist, director, Prachi Nursing Home, Cuttack, Indian medical educator, president Foxy 2011, president IMA, vice president Foxy 2004, and chairperson medical education committee, Foxy from 2002 to 2007. And organizing secretary, 45th AACOG, Bhubaneswar, and joint organizing secretary, Association of Gynecologists of India, in Cuttack 1997, executive member, Indian Society of Perinatology, ISOPAR, and many research papers and publication. I welcome you, sir. Now I request Sujit to read the CV of Janmejay, sir.
I am very much glad to introduce Janmejay, sir. Everyone knows him, but for newcomers, it is essential to know all the facts. He is a professor, head of Department of Gynaecology, Acharya Harihar Postgraduate Institute of Cancer, Cuttack, Odisha. Various organization positions have been held by him. Vice President Foxy 2024, Treasurer AGOI 2022-24, Treasurer AICOG 2018, Chairperson Clinical Research Committee Foxy 2013 to 2015, Joint Secretary Foxy 2011, Chairman YGOG Committee of Association of Gynaecological Oncologists of India 2017 to 2019, Chairperson Preventive Oncology and Public Awareness Committee, and he is Joint Organizing Secretary ASOG 2002 Bhubaneswar. He is Organizing Secretary Society of Vaginal Surgery of India at Bhubaneswar 2018, Treasurer SOVSI, that is Society of Vaginal Surgeries of India 2018, it is in continuation. Organizing Secretary Purvam 2017, Vice Dean IMA College of General Practitioners, Headquarter HQ from 2020 to 2022, National Joint Secretary IMA College of General Practitioners 2018 to 20, Honorary State Secretary IMA Odisha from 2016 to 20, National Chairman IMA Standing Committee of Medical Education for 2013 to 15, life members of IMA, Foxy, AGOI, IMS, IAGE, ISAR, ISPAT, and ISOPAP. Various awards under the name of Dr. Janmejay sir. IMA National Award for Best Dedication to IMA CGP Activities 2022, IMA National Award for Best State Secretary IMA 2016-17 and 2018-19, IMA Special Award for organizing 21st Working Committee meeting held at Puri. Various publications are under his name. Numerous publications are there from proxy and gynecological oncology journals. And field of special interest are gynecological oncology and endoscopy. Welcome, sir.
Thank you. Thank you, Sujit, for your kind introduction.
Welcome, sir. Now,
regarding this topic of non-descent vaginal hysterectomy, as such, all the people of Odisha are very, very good in doing vaginal hysterectomy.
Yes,
Sir.
yes.
Yeah, I know.
PC
Right from
sir is
PC
our
sir.
guru. PC sir is there. He is
Yeah,
our guru. He has started the SAPSI, Society of Vaginal Surgeons of India. Sir is the brain behind the society.
Yes, sir. Anything to convey, sir, for this webinar, through this webinar? Janmay sir.
Yeah, okay. Okay. Thank you, Radha.
Thank you, sir.
Good evening, everybody. Our chief guest, Dr. P.C. Mahapatra, will join very soon. Respected sir, and respected guest of honor, Professor Bhagyalakshmi, conveners, Dr. B. Radha Lakshmi, Secretary, Kundal Society, Dr. Urgesan, President, Kanchipuram Society, Dr. Sujit, Vice President, Society of Fetal Medicine, Marathwada Chapter, Dr. Shweta Jha, all the office bearers of Andhra Pradesh, Tamil Nadu, Madhya Pradesh, Odisha, and Maharashtra Obstetric and Gynaecological societies, speakers, experts, chairpersons of this important CME, my senior teachers, friends, and dear Bhakshians. It gives me immense pleasure to be the guest of honor in this prestigious webinar organized by the three veteran Bhakshians, Dr. Radha Lakshmi, Dr. Urgesan, and Dr. Sujit, coordinating and in association with all the societies with 5 states of India. I congratulate the three conveners of the CME. Today, the talk on NDVH, a different situations by Dr. Anil and another talk by Dr. Tapasi, management of will be very much helpful and informative to all the participants in their day-to-day practice. I welcome all the delegates to this very important and informative webinar, and all the best wishes to Dr. Radha Lakshmi, Dr. Shweta, Dr. Murgeshan, and Dr. Sujit for the upcoming Pakshi election. Long live Pakshi.
Thank you, sir. Thank you for your kind words.
Sahiti, CV of Bhagyalakshmi. Bhagyalakshmi Madam is professor in the Department of Gynaecological Oncology, Cuttack, past co-chairperson Oncology Committee, SAFAC, Governing Council member ICOG, Chairperson Oncology Committee, FOXY 2018 and 20, Secretary EGOI, Peer Reviewer of Indian Journal of Gynaecological Oncology, Indian Journal of Surgical Oncology, Journal of Obstetrics and Gynecology of India, BMC Cancer. Madam has been selected as unopposed Vice President from East, and congratulations to you, Madam. And more important is, Madam is down-to-earth person and she is approachable at any time. Thank you, Madam, for joining the webinar. And
thank you so much. Thank you so much, Radha. I think we are missing sir. I think he'll be joining shortly. But
yes,
then this is actually the spirit of Foxy. You
yes,
have brought half of Foxy into your this webinar today.
Thank you, Madam.
I think this is the spirit, and you have brought so many people around. Dr.
This
Smita,
is the
Dr.
second
Sujit,
webinar like this.
Dr. Umair.
Yeah, thank you, Madam. Please continue, Madam.
It actually functions. So I think my best wishes to all of you, and I think it will be educative webinar also. So Tapasi is a nice speaker, so we'll hear from her. And I think should we wait for sir or you start the webinar?
We'll continue, Madam. We'll continue, madam.
Yeah,
Because
I think we
Anil
should,
Thackeray are having one more webinar.
Yes.
Better, better
Thank
to
you so much.
continue.
Thank you so much.
Sir will join.
All of you.
In between,
Thank you so much and many best wishes.
Thank you so much, madam. Sahiti?
Sir will
Next.
join in between. You
Okay.
please start.
So Venkatramana sir is the president of Kurnool OBG Society. He trained in laparoscopic surgery, 25 years of service in Kurnool Medical College, Kurnool, professor, assistant professor and HOD, retired from KMC Kurnool. He is the alumni of KMC, IMA Vice President, Dhira Awardee, Best Doctor Award, President Kurnool OBG Society, AP State DPL Trainer. Welcome you, sir. Venkatramana sir, are you there?
Thank you. Yes, I'm here.
So now I want to introduce the chairperson, Dr. Sunita Vadvani, President Ratlam Obstetrics and Gynaecological Society, Director, Consultant, Ratlam Hospital and Research Center, NABH Accessor, MBA in Hospital and Healthcare, Special Interest in Clinical Obstetrics, and Lead Accessor and Master Trainer in Manyata by Foxy. I welcome Sunita Madam. Next is Dr. Aditi Rathore. She did MS OBG in Hospital Administration Affiliation, Rathore Nursing Home, Ajora, Position Consultant, Rathore Nursing Home, Achievements, International National Conference, Faculty, Receiver of PMSMA Awardee, Secretary, Rathore Obstetric Gynaecological Society, Executive Member of OMPAX, Executive Member of Safe Motherhood Committee. I welcome Aditi Rathore Madam. And Sujit will introduce Sunita Madam.
Yeah, I would like to introduce and welcome Dr. Sunita Chauhan ma'am. She is a gynecologist, obstetrician, infertility specialist and gynaecolaparoscopic surgeon, head of department gynecology at Kokilaben Dhirubhai Ambani Hospital, Indore, secretary Indore Obstetrics and Gynaecological Specialist Association 2024-25, Madhya Pradesh IAGE Executive Committee member, lifetime member of IAGE ISAR IMA and Menopausal Society, organizing co-chairperson, chairman MSCon 2013 Indore, examiner in FMAS exam 2020 Ujjain, core team of the organizing committee of AICOG 2022 Indore, treasurer West Zone Vice President Conference 2023 Indore, and she is having special interest in gynec laparoscopy surgery. Welcome, ma'am.
Thank you.
And I would like to introduce and welcome Dr. Sujata Kumari. She is MBBS MS DNB MRCOG, IVF consultant and laparoscopic surgeon at Jayaprakash Hospital, Rourkela. She is a life member IMA RCB ISOPAP, secretary of Rourkela Obstetrics and Gynaecological Society, special interest in IVF, and she is a teaching faculty of DNB training in Jayaprakash Hospital, Rourkela. Welcome, Dr. Sujata Kumari.
I request Sunita Chauhan Madam to introduce our speaker of today, Dr. Anil Thackeray sir.
Yes, welcome Dr. Anil Thackeray sir.
Thank
He
you.
has done MBBS, DGO, DNB, DFP, FICOG and ex-associate professor, Department of Obs-Gynae, DR, SC Government College, Nanded. Worked as an assistant professor at GMC Nanded for 11 years, and postgraduate teacher and examiner, operating faculty of live surgical workshops at various national and international conferences, 23 scientific publications in various national and international journals, amongst very few Indians who have contributed to Williams Test Book of Obstetrics, contributed to International Reference Book of Operative Obstetrics by Cunningham, served to African countries and operated hundreds of the cases there through Rotary Medical Health Camps. Experience of operating more than 7,000 NDVH cases, organizing secretary of AMOX 2012 to 2017 Nanded, received many awards for his social services and contribution in the field of photography, peer reviewer on editorial board of prestigious journal of Foxy Jogi, co-editor Foxy Focus on Vaginal Surgeries, chairperson AMOX Vaginal Surgery Committee 22-23, president Nanded Obs-Gynae Society 2024, director of IVF Center Nanded. Welcome, sir.
Thank you very much.
Sir, you are having so many adjectives, sir.
Thank you, ma'am. At the outset, I must thank Radhalakshmi ma'am, Dr.
Yes, sir.
Sujit for inviting me for today's webinar. I must thank to all our chairpersons, Dr. Sunita ma'am, Dr. Aditi ma'am, Dr. Sunita Chauhan ma'am, and Dr. Sujata Kumari ma'am. Even I must thank our expert, Dr. Venkata Raman sir, who is senior OBGYN from Kurnool, with all these in front of dignitaries, I will start my presentation. I wish what we call Eklavya of vaginal surgery, Dr. P.C. Mahapatra may join in between. So, as rightly said, Mohapatra sir, that the Odisha is the core of having a core team of vaginal surgeons, and I learned of many things from all these stalwarts from Odisha, and I must thank to all these stalwarts in this field. So I will share my screen with the permission of chairs. I will start my presentation. Are you able to see the screen, Sujit?
Yes, sir. Yes, sir.
Yes.
Yes. So individual in difficult situation. We know that place of vaginal hysterectomy for undisputed uterus is very common in in the initial years of 1900 and 1910 20. But initially it was done only for prolapse cases. Now the escalation of this surgery and the
Sir, you're muted, sir.
No, there is some net problem, I think, on his side.
So we know that the NDVH non-distant vaginal hysterectomies are being performed by many vaginal surgeons for common cases like a small normal size uterus or a uterus just bulky for AUB cases or DUB cases. But now the indications for vaginal hysterectomy, which were contraindications previously to perform these cases vaginally, now now they can be very easily performed by vaginal route with augmenting your skills. But there are some difficult situations where we need some skills to perform these cases by vaginal route. And from my point of view, these difficult cases or the difficulties which we may encounter in performing vaginal hysterectomy in such cases is like big uteruses like fibroid, multiple fibroid, irregular uteruses, even big uteruses like adenomyosis. In case of pelvic adhesions because of previous surgery, previous cesarean section, or there is a need of concomitant oophorectomy or salpingectomy, which was a relative contraindication 40 years back, that if you want to do an oophorectomy, that surgery should be performed by abdomen. No, nowadays, the role of concomitant salpingectomy along with hysterectomy is there in prevention of ovarian cancers. So salpingectomy can be done by vaginal route with difficulty. Benign adnexal masses, obese patients, lacerated cervix, and cases with previous cesarean section. All these cases are a little bit difficult from the ordinary cases which are being done by vaginal route. But all these cases are not an absolute contraindications to perform by vaginal route. They are relative contraindication. And with the surgeon's skill augmentation, all these cases, all these indications, they can be performed by vaginal route. So how can my presentation will be that henceforth is that how can we make these cases easy? How can we make these cases by vaginal route? So there are some tips and tricks to perform all these cases by vaginal route for handling the difficult cases and to minimize the intraoperative complications. The first indication is that the big uterus with fibroids or big uterus often adenomyosis. Fibroids may be in a multiple fibroid or a single fibroid. And there are absolute contraindications to perform a vaginal hysterectomy in a case of fibroid, a bigger size of fibroid, fundal fibroid having transverse diameter more than 10 centimeter. All these are relative contraindication for vaginal surgery. But the multiple fibroids of small size, they can be easily removed by a vaginal route. Even the cervical fibroid polyps, with this condition, the hysterectomy can be performed by vaginal route. What we need is that a bigger size uterus, what it needs to reduce its size. So debulking techniques is a gold standard to perform hysterectomy for such bigger sizes uterus. This debulking techniques reduces the mass of uterus, and delivering the uterus and applying the corneal pedicle will be easy after doing this debulking techniques. There are various types of debulking techniques are there. The last technique, that coring technique, is one of the best technique where you can debulk the uterus. You have to core the uterus in the myometrium all around the uterus, beneath the serosa, so that the mass of the uterus can be reduced and it can be delivered very easily. This technique was initially introduced by Lash, and it is also named as a Lash technique of a debulking. The only golden rule for doing any debulking technique is that you have to perform this debulking technique after the ligation of uterine artery. That is the basic rule. So you should not perform any debulking technique before ligation of uterine artery. Otherwise, there will be a profuse hemorrhage. The bisection and morcellation are the other two techniques where you can debulk the uterus. The bisection technique is preferably very important where the cervical elongation is there, especially in case of previous cesarean section, where you can cut the uterus in two halves and deliver the uterus. The morcellation, bit by bit, whatever comes in your surgical feed, you can make small pieces, brick-like pieces or some small pieces. You can, with this technique, you can reduce the mass of uterus and you can easily remove the uterus. So even a cervical fibroid polyps, they can be removed very easily. The basic rule is that you just first do the polypectomy by just screwing movement, as in this case. Just do the screwing movement and remove the polyp. There will be no bleeding, as this screwing movement will obliterate the feeding vessel to this polyp. And after doing a polypectomy, you can rest of the hysterectomy can be completed as a routine usual steps. Previous cesarean section, this is a very important difficult situation in performing vaginal hysterectomy, and as all we know that the rate of cesarean section is rising in such a way that in coming 10 years every alternate hysterectomy will be having a history of previous one cesarean section and previous two cesarean sections. But believe me that this doing a hysterectomy in previous cesarean section was a relative contraindication a few years back, but it is not an absolute contraindication to perform hysterectomy by vaginal route. Rather, vaginal route is the best route to perform hysterectomy in cases of previous cesarean section as compared to other routes. The mainly concern with this is that adhesions, the fear of injuring the bladder, and the long service need to take multiple clamps, particularly uterosacral and McIntosh. These are the concerns while performing these surgeries by vaginal route. So, how to open the anterior and posterior pouch? There are various techniques described to approach for anterior and posterior pouch. But which are the cases they are really contraindicated for vaginal route? Cases of previous cesarean section which are really contraindicated for vaginal route. That is the only condition where the uterus is fixed at the anterior abdominal wall, what we call as a ventrofix use. If you find that the uterus is ventrofix, it is almost an absolute contraindication to perform vaginal hysterectomy. So how to diagnose such cases? Very simple. To diagnosing a ventrofix use is very simple. By OPD, you can diagnose that uterus is ventrofix. The high placed cervix may give a suspicion that uterus is fixed anteriorly to the abdominal wall. And second test, that is the confirmatory test. If you pull the cervix, the anterior abdominal wall will get pulled down. This is an absolute diagnosis that the uterus is anteriorly fixed to the anterior abdominal wall, and these are the cases for contraindication for doing vaginal hysterectomy. Rest of the cases you can easily perform by vaginal route. So anterior, how to dissect the bladder? The main fear for dealing with such is that a bladder injury or you can make a bladder injury, or it is very difficult to open the A pouch or a P pouch many times because of adhesions. So there are various approaches. The main approach which was described by Series states are that the lateral space, series state space, you can see after uterine ligation, there is an avascular space laterally. So you can open the anterior pouch at this space and then dissect the scar. This is the easiest method to deal with a bladder in a case of previous cesarean section. Go in the avascular space, which is called a series state space. And believe me that all laparoscopic surgeons dissect the bladder in case of previous cesarean section uh, by going in this avascular space, and then they dissect the bladder. So series states, recognizing the series state space and dissecting the bladder is the key step to deal with the bladder in case of previous cesarean section. Other routes are there, other techniques are there to dissect the bladder or to go for a pouch is the anterior pouch is that go from open the posterior pouch, insert your fingers anteriorly, and with the help of your fingers you can dissect the bladder. But this technique is only possible when if the uterus is of a normal size. So you can go all around to the uterus and inserted your fingers and they can come anteriorly, and with the help of your fingers direction you can dissect the bladder. Third technique is that you can go sharply. Sharp dissection is done to the bladder scar or cesarean section scar, and you dissect the cesarean section scar directly, and you can enter in the anterior pouch. The fourth technique, which I follow in many cases where I don't have no confidence that to where is the cesarean scar, where is the bladder. If there is difficulty in identifying this tissue, go intentionally in the uterine tissue and dissect the cesarean section scar. This is also a very beneficial technique where you can avoid the bladder injury. And the evidence says that the risk of bladder injury during vaginal hysterectomy does not seem to be increased in women with previous cesarean section. So don't worry that there will be very less bladder injury as compared to abdominal or laparoscopic route if we compare the vaginal route for hysterectomy. So the other concern with previous cesarean section or previous cases of previous laparotomy, that is, or cases of chronic PID, the POD adhesions. So if there is a POD adhesions, there will always we have a fear that we may directly injure to the small bowel or the large bowel, or we can directly open to the sigmoid or a rectum if they are adherent to the pouch of Douglas. That is really a challenge in such cases, and we can diagnose that there is an adhesion in POD by just doing a per speculum examination. You can see that the posterior pouch, that POD is puckered. So it is the POD is taken up upwards. That puckering sensation, puckering vision is there, and you may suspect that there are the adhesions in the pouch of Douglas. So how to go with such cases is that there is a simple technique, that is cervicocolpotomy. Don't open posterior pouch directly. Take a vertical incision directly into posterior lip of cervix, and you can see that you open the pouch of Douglas at its tip. So there are very less chances that you can injure the bladder. This is the simplest, very good technique to avoid bowel injuries in case of puckered pouch of Douglas or a suspicious cases of adhesions in the POD. So this simple technique of cervical colpotomy will avoid bowel injuries in such cases. So vaginal oophorectomy or concurrent salpingectomy or adnexectomy, so was previously said to be a relative contraindication to perform vaginal hysterectomy because of fear of restricted access to the ovaries, inadequate visibility of adnexia during conventional vaginal surgery. Good surgical practice dictates that objective determination of the visibility and accessibility of the ovaries be the primary criteria for selecting a particular route of hysterectomy. But all of us know that the commonest route for tubectomy in 1970s up to 1978, even Dr. Shirodkar and Dr. Purandre, they have performed thousands of tubectomies by vaginal route. Why? Because this shows that the tubes are very easily approachable by vaginal route. So concomitant salpingectomy is no more a contraindication to perform hysterectomy by vaginal route. Regarding oophorectomy, this grading, there is a Bandon and Walker describe very nice that grading of the ovaries. So ovaries can be graded in some grades. They describe that The grade 0 to 1. Grade 0 to 1 are the ovaries. When you pull the cervix, ovaries, they will never descend. They will remain at the level of ischial spine or above. This is ischial spine, and even after traction, these ovaries don't move. They remain stuck there. This indicates that ovaries are adherent at the posterior or lateral wall of the abdominal cavity. In cases of previous surgery or cases of endometriosis or cases of chronic PID. So these are labeled as a grade 0 to 1. The grades 1 to 2 are those ovaries, they remain in between the hymenal ring and the ischial spine. So these grades are described. The uppermost margin is ischial spine and lowermost margin is hymenal ring. So grade 1 to 2 are midway between ischial spine and hymenal ring. Grade 2, they are just touching to the hymenal ring. And grade 3, many a times in case of prolapse, you may say that after pulling, the ovaries come out of the vaginal orifice or outside the hymenal ring, they are grade 3. So this grading is very much helpful. If you find that the grade 0 to 1 ovaries, they are really difficult. These are the difficult cases in which oophorectomy is difficult by vaginal route. Many times you may have to take a laparoscopic assistant to perform oophorectomy in such cases. But believe me that these grades of ovary are found only in 1% of cases. Only in 1% of cases. 99% cases, study shows that the ovaries are at the grade of grade 1 to 2 or grade 2 or grade 3. So in all these grades, the oophorectomies can be performed very easily with a very less skills. But the grade 0 ovaries, they are very difficult to remove by vaginal route. So many times you may have to take a laparoscopic assistant, but the number of such cases is very less. So 99% time we can perform salpingectomy or salpingo-oophorectomy very easily in case of vaginal hysterectomy. Some have developed to again make easy this oophorectomy, that oophorectomy clamp. Now this is series set oophorectomy clamp having a longer curve so that you can apply the clamp lateral to the ovary very easily, and there are less chances that pedicles will get slipped. So these clamps are used nowadays. Electrocauteries are used to perform oophorectomy easily, avoiding the slippage of clamp. But I follow this simple technique to perform oophorectomy. We don't need any special kind of clamp. We don't need any special kind of electrosurgical instrument. This is the Zimmermann technique of oophorectomy. This is not any different technique to perform. This is the same technique which we follow to perform oophorectomy in abdominal surgeries. This mimics same maneuvers that are used to remove the adnexata abdominally. You can see the Zimmermann technique. For performing, you have to clamp the round ligament, clamp, cut, and ligate, and just create a space in the broad ligament lateral to it. So this will, so after cutting the round ligament, we have to dissect the broad ligament just beside to this round ligament so that we can apply the clamp very easily laterally. You can see it's so easy, nothing special clamp, nothing special cautery. So this is Zimmermann technique by which you can perform oophorectomy very easily while performing the vaginal hysterectomy. Even the same with the salpingectomy. You have to just apply the clamp lateral to the tube, just pull the tube downwards, apply the clamp laterally, and perform the salpingectomy. So, and nowadays it is said that salpingectomy shouldn't be performed with vaginal hysterectomy because trade-off with cancer prevention is highly favorable. So, we may find some adhesions while performing salpingectomy, oophorectomy, especially in cases who had undergone previous tubal ligation by mini lap technique or by laparoscopic technique, what you're doing. And these small adhesions, they can very well easily deal with vaginal route. No need to convert this hysterectomy into abdominal. Just many times we may find the omental adhesions adjacent to the tube or ovary, and they can be ligated and cut, and the rest of the hysterectomy can be performed by vaginal. So even these adhesions, small adhesions of omentum, sometimes bowel adhesions at the lateral edge of the, especially in the left side of the ovary, the anatomical adhesions might be there. So they can be easily dealt with by vaginal route. No need to take any laparoscopic assistance in such cases. Even the benign adnexal masses, we have a separate lecture how to deal with adnexal masses. But even benign adnexal masses, they can be easily, very well removed by vaginal route. But just you have to mark out by whatever the technique, by ultrasound or by carcinoma, serological markers, you have to rule out the malignancy in such adnexal masses. And if they found that you find clinically and by with investigation that they are benign, they can be removed very easily with vaginal route. So, whatever the size maybe of the masses, the mobile adnexal masses, they can be removed very well by vaginal route. Even bilateral masses, they can be removed very well. Bilateral adnexal masses, hydrosalpinx or bilateral ovarian tumors, they can be easily removed by vaginal route. Even bigger sizes ovarian tumor. See, this is almost a 28 to 30 week size ovarian tumor, simple route. You can reach up to the wall of the ovarian tumor, drain out the cystic fluid from the tumor and remove the ovarian tumor. So no need to do a laparoscopic or abdominal surgery or even such bigger size of wound. They can be dealt with very easily by vaginal route. Only thing is that you have to rule out malignancy, whatever the investigation you have with either iota classification by ultrasound or some markers like CA125 or CA marker 14, whatever the markers you have with you, you have to just rule out, or even a Doppler also, they can help to rule out malignancy in such ovarian tumor. Now, the main fear while performing any hysterectomy, either abdominal, laparoscopic, or vaginal, there is always a fear of ureteric injuries. We may injure the ureter in such surgeries. And believe me, all evidences says that vaginal hysterectomy have a least incidence, and this is the grade A evidence which we have up till now, till 2023, that the vaginal hysterectomy has a least incidence of ureteric injuries as compared to abdominal or laparoscopic or even a robotic surgery also. So why this is big? Why this is because when we do just simple technique, give the traction downwards and the opposite side. Suppose you are dealing with a right-sided pedicle, give the traction on the left side downwards. And if you are dealing with the right side of the pedicle, give the traction on the left side and downwards traction. Opposite side, downward traction. How it will help? This simple maneuvers just took you are 4 centimeters away from the ureters. Even a skilled surgeon, if you ask to injure the ureter in such cases, he will not able to injure because he will not find any ureter because you are far away. Your anterior, the upper speculum is retracting the bladder, lower speculum in the pouch of Douglas, traction on the opposite side and opposite direction and lower side. It will move your surgical site 4 centimeters away from the ureter. So there are least chances that you may injure. But it is not like that. You may not injure ureter in vaginal surgery. And after the years of experience, what I find, even I injured the ureters in few cases. And what I find that in which are those cases where I injured the ureter, and I found this main culprit, particularly the cases of adenomyosis, cases with which are having a very less decent, cases which are having the adhesions. And in such cases, particularly in cases of adenomyosis, where the uterosacals and Macken-Rods got shortened because of fibrosis, shortened and thickened. And when you try to ligate and cut, many times few fibers may get away from your pedicle and they may bleed later on. And when you try to religate this pedicle, there are high chances that you may go more laterally and you may injure the ureter in such cases. So my suggestion is that when you are religating the pedicle, even though if you are doing a vaginal hysterectomy by using bipolar clamp, never cauterize for religation or to acquire the rehemostasis. Always ligate, don't cauterize, don't use bipolar to achieving rehemostasis. So these are the really cases where are high chances that you may injure. So what is the techniques that you may not come around the ureter? The simple technique. So this is the after hysterectomy, I found that there is a bleeding to this thickened, shortened uterosacral. So see how to deal with such cases. Just reclamp the pedicle, and your needle should kiss the pedicle, your edge of the pedicle. Your needle should kiss the edge of your pedicle, so that will avoid the injury. That will avoid taking the ureter in your bite. You have to keep watch on your needle. It should be just kissing to your clamp. Don't go more laterally, just and retract bladder very nicely. Pull the pedicle just downward so that you will be away from the ureter and then religate it. So it will avoid the ureteric injury in such cases. The other main concern with vaginal hysterectomy is walled granuloma. There is a little bit higher incidence of walled granuloma in cases of vaginal hysterectomy. There are many reasons, but the main reason is because of improper approximation of a vaginal wall. But the main thing is that the patient comes to you with this granuloma. She said she is having bleeding. So there is always in a mind of patient that her operation has been done not done properly, or half of the operation done, half of the uterus still is inside. These are my experiences, what patients say. But dealing with this granuloma is very simple, no need of any admission, or it is a daycare procedure. Either you have to remove this with the help of electrocautery, or even a just simple twisting can remove this granuloma, or even chemical silver nitrate solution you can apply to remove this granuloma. Reassurance is very important in such cases to the patient that this may happen and this may happen again also. The technique not to have a walled granuloma is that I usually close the vagina by mattress suture. Intermittent mattress suture. Just take 3 to 4 intermittent mattress suture to close the vagina. What will it help? It will help the proper approximation of the vaginal wall, which may prevent formation of a walled granuloma. Improper approximation of the vaginal wall, anterior and posterior, may lead to formation of a walled granuloma. So this is the tip to prevent the walled granuloma in case of vaginal surgery. The other fear of doing a vaginal hysterectomy is the formation of a walled hematoma. But believe me, this is my own paper along with, we did a study with our stalwart laparoscopic surgeon, Dr. P.G. Paul, which was published in the international journal that is on gynecological surgery. And this paper suggests that there is a high incidence of walled hematoma in cases of laparoscopic surgery as compared to the vaginal surgery. So vaginal surgery has a least incidence of walled hematoma as compared to other two routes. So again, the last concern with vaginal surgery is the walled prolapse. But believe me that till today we don't have any evidence that vaginal surgery, either laparoscopic or either abdominal surgery, have a higher incidence of walled prolapse. We don't have any evidence of any either surgery. But there is an evidence that walled incidence of walled dehiscence is higher in cases of laparoscopic or robotic surgery as compared to abdominal or vaginal surgery. Walled dehiscence is very common with laparoscopic surgery as compared to vaginal surgery. But what can we do to prevent walled prolapse in such cases? And I usually perform McCall's full Doppler, not the whole procedure, but I usually take external McCall stitch to support the vaginal wall in cases of vaginal surgery. And McCall in 1957 described this procedure, and believe me, this is the very gold standard procedure to prevent the walled prolapse, even to treat the walled prolapse in cases of walled prolapse post-hysterectomy. So this is the simple technique of an external McCall stitch, where you have to insert the needle in the vaginal wall, then take a bite in the uterosacral McCall complex, high up peritoneum posteriorly, again come to the opposite sides of McCall uterosacral complex, and then bring out your needle at the 7 o'clock position and tie this stitch after the closure of vaginal wall, which gives an excellent support to the wall to prevention for wall collapse. So to conclude, skill augmentation for vaginal surgery can avoid need of costly endoscopic surgeries. With increasing confidence and skills that comes from experience, there are very few patients with indications for hysterectomy in whom the procedure cannot be performed vaginally. Vaginal hysterectomy can be performed easily in case of previous cesarean section and the cases which need oophorectomy and salpingectomy. Because of little more intraoperative complication rate, such special situations should be undertaken after good experience. And at the end, I must thank to the organizer for giving me this opportunity. Nothing is difficult. Learning and practicing tips and tricks make it very easy and simple. Thank you very much.
So PC sir joined. Sir, good evening, PC sir. Your expert opinion regarding non-design.
Namaste, sir. Mahapatra, sir. Good evening. Namaste.
Good evening, sir.
Good evening, sir.
Welcome.
Good evening, sir.
Good evening.
Thank you so much, sir, for joining.
Good evening, sir.
Sir, you are expert.
Namaste, Bhagya coach.
Sir, we need your opinion, sir. Vaginal
We
surgery.
need.
Oh, sorry.
Sorry, sir.
At the outset, my sincere apology to all of you for joining late.
No, sir. Your joining is enough, sir.
And I'm physically strong, digitally very weak. I tried while coming back in my vehicle with my phone, and the link says that it's a registered one has to register. I don't know how to register it and all that. However, I beg excuse again for joining because my favorite Tumial and Radha Lakshmi has already briefed me earlier, told me about 1 week back that they are going to organize a very important webinar. At the outset again, I welcome everybody and thanks the conveners, the great vibrant leaders of Foxy and V. Radha Lakshmi from Kurnool and Dr. Umial from Tambaram and Kanchipuram Society has formed it, and the pillar of Society of Fetal Medicine, Dr. Sujit, the guest of honor, both once upon a time were my students, now they are my teachers. Professor Bhagyalakshmi,
teacher.
Janmejaya Mahapatra, and all the stalwarts present over here. I again welcome the two veteran speakers of these two sessions. First session on NDVH, which I have observed last 10-15 minutes. I have seen that. And I congratulate Anil, Dr. Anil, and the expert, Dr. Venkat Raman, for that first session. And along with the great, beautiful brain and beauty combination of chairpersons, Sunita Aditi, Sunita and Sujata Kumari. And in the second session, Poonam Jha, Sweta Kaul, Subhasini and Narendra Jop. And the speaker in the second session, again, one of my student, Professor Tapasi Pati, will be speaking on another aspect on management of adnexal masses for that. And therefore, Umial and Radha Lakshmi madam, I think you are apt to select two very important topics which will be delivered in the webinar in a very delicate way. One on NDVH and difficult situations focused, and another on management of adnexal masses for that. It's not a confusing and it's not a whole day a CME on a particular aspect. It is a focused particular on two different subjects, which is a day in and day out. All the gynecologists face a problem, and that is you have addressed it. And that's why I congratulate both of you for selection of that. And I hope the contents of that will really enrich and update the viewers across who are observing this particular beautiful webinar by the leaders of Foxy for that. Again, I'm very thankful that I've joined here. I've listened to some tips and tricks of the vault prolapse and how the vault preventing hematoma by the great vaginal surgeon Anil. And I hope the expert opinion subsequently followed by Venkat and the whole masses with the guest of honor and the chairpersons. I think I'm really happy to be associated with you in this particular seminar. Again, I beg apology for joining late for that. Thank you very much.
Thank you, sir.
Sir, today I have a feeling that I am presenting my topic in front of Dronacharya.
Nahi,
What
nahi.
we all A-levels have learned, listened, and all the things with the Stalovas like that. We are all A-levels from all the Foxy team.
All
We
of
are
us
very
are your students, sir.
Slide is very catchy and all that. Anil, nothing is difficult. My teacher once upon a time told, every surgery is easy. Every surgery is difficult. It is the surgeon who makes the surgery easy or difficult. I think that's exact you have made it. And really this is essential. And I congratulate you to be associated with the great leader PG Paul in publishing that in that particular book. I have gone through that and really I appreciate the steps of that. Thank you.
Thank you, sir, for your valuable words. Really.
Thank you, sir. Thank you, sir. Thank you for joining.
Thank you.
Need your blessing, sir. Sujit, myself, Umayil, sir.
You are true. You are true. I think all these things, this is a webinar is one aspect and you are through. You are really, we want good Foxy. I hope that will be done.
Yes, sir.
Thank
With
you,
all
sir.
your blessings, we are hoping, sir.
I wish.
Yes.
Sir, my doubt is, sir, is it possible to do only ovariectomy without removing the tube? No, salpingectomy without removing the tube, ovary, sir, during vaginal hysterectomy. Removing only tubes.
Yeah.
It's very easy.
It's not a very difficult procedure and all that. And see, you can remove by vaginal route tubes, ovaries, and you can remove also appendix. You can remove higher up also, and gallbladder is going for that more and more for vaginal route. And
tonsils, tonsils.
But only thing I will delegate.
Tonsils.
Don't have the right thing for that. Don't think that our
So most of the times,
cuts.
salpingo-oophorectomy is done, sir, instead of doing only salpingectomy.
No, salpingectomy, the concept came from the history, from the origin of the papillary serous, high-grade serous carcinoma of the ovary, that the distal part of the tube is responsible, and that's why we are here. Once upon a time, even there is a hydrosalpinx, we preserve it, thinking that the blood supply will be there to the ovary. But now, when it's proved, I think opportunistic salpingectomy has been routine, and I always do a salpingectomy always, and it's not at all a difficult procedure, and more so when you're using a vessel sealer. When you're using a vessel sealer, I think it's much more easier for that. It will take few seconds to do that salpingectomy for that. And if you want to remove the ovary and the tube, I think the same way when we do it abdominal, you just separate it from the round ligament and then go to the infundibulal ligament, and always under vision. Only thing is that the vision is very good, should be there, and you should with a sponge and all that, you should retract the bowel coming in between that. If you are using the vessel sealer for that. If you are suturing, that's all right. But I think I've left suture for last 15-20 years, and I'm very happy with this procedure with the either removal of the ovary and tube. I think I again say that opportunistic salpingectomy is a mandatory procedure for that also, and therefore it should be done in that particular case.
Yes. Yes, sir. Vessel sealer has really helped us for vaginal surgeons to do the surgeries. Even difficult surgeries are now looking much easier. Yes, sir.
Years, more than 20 years back, when we were doing I demonstrated this as a vessel sealer and all that. I find some of the comments that ye tandoori surgeon hai, tandoori kar deta hai. So that science is growing. Maybe that the another thing will come, then this vessel sealer will also go. You look at it and everything will be dry for that also. You wear a goggles and look at it and everything will be dry for that. You enchant a mantra, everything will be on and all that. No cutting and all that will be necessary.
Sir, my one question is that being in a stalwart, how you see the fate of vaginal surgeries in future as considered to the glamorization of laparoscopic and robotic surgery?
Pardon? I couldn't understand.
How you see the fate of vaginal surgeries against the glamorization of laparoscopic and robotic surgery?
Well, I always say that either a big hole surgery or a keyhole surgery or a no hole surgery. Option is yours. It's a no-hole surgery, and it's a signature of the gynecologist. No surgeon can dare to do it for that. And therefore, I think vaginal surgery, even all the literatures, evidences also says that when Harry Rich also says, who has found out the laparoscopic hysterectomy. If vaginal hysterectomy is feasible, laparoscopic hysterectomy is to be condemned. This is the version of this Harry Rich. And therefore, all the evidences, they say that it is not only the best, it also should be the most. But unfortunately, 90% of the so-called TLH can be tackled by vaginal route. The screening is important. At the same time, I can say that there should not be any dogma in science. If I am a vaginal surgeon, I always say all cases should be done by vaginal. If I am a laparoscopy, all cases I will do a laparoscopy. That should not be the scientific modality. Dogma should not be there in science. And laparoscopy is helpful for the vaginal surgeons. I think the vaginal surgeons, if a laparoscopy is there, I think they can do more and more difficult cases of vaginal hysterectomy is possible by doing the laparoscopy when specialist for scope is there for that. So one should not be dogmatic for that. But I think I love vaginal surgery. I'm a lover of vagina. Anil, I'm not a lover of umbilicus.
Well said, sir. We all
Sir, one doubt, sir. Is there any advantage of V nodes over vaginal hysterectomy?
I'm not very knowledgeable regarding V nodes. I'd met the young dynamic person who started, but I cannot comment on V node because I am not I've not seen a V node surgery for that also. Only theoretical aspect I have seen. The merits and demerits I have not seen for that. But whether vis-a-vis V node vaginal or V node laparoscopy, I can't comment on that.
Venkatramana, sir.
Very nice presentation of difficult cases of vaginal hysterectomy by the stalwarts and PC Mahapatra sir's expert opinion. It is added to the webinar. Thank you, sir. Thank you very much for. And I request from Kurnool Society, so help all the people who are contesting now from Kurnool and other madams, two madams, sir. Thank you.
Not only Kurnool, but all over India.
It's all over India. Kurnool, sir. Because we are contesting from, and Mumbai madam and other people also, so we have to help them, sir.
Aditi Rathore, madam. Your comment, please. Aditi, madam.
Yes, ma'am. First of all, thank you for having me here. My regards to Mahapatra sir and all the seniors here. And there's nothing more for me to add after Mahapatra sir's comment. He has summarized it all. Anil sir, I would congratulate you for such a big, nice, lucid talk. You covered each and every aspect, and it was actually an eye opener. And I enjoyed. A cervical colpotomy, the method, I found it very nice. And also, you basically what I understood is that if learning and experience is very important in doing NDVH, and if we should train our juniors better, and they should, as sir rightly said, Mahapatra sir said, we should not be adamant and know what is best for the surgeon, for the patient, and advise accordingly. And laparoscopic help, a scope inside might go a long way in helping vaginal surgeons. Thank you so much, and all the best, Radha Lakshmi ma'am, Umayal ma'am, Gonkar sir, and Shweta Kolja. My regards to you all. All the best. May you all emerge as winners. Thank you so much.
Thank you. Sujata Kumari, madam. Are you there? Sujata Kumari. Roorkela.
Madam, unmute, please.
Good evening, ma'am. Sorry, ma'am, I was listening throughout the session, but could not interact properly. And about this vaginal surgery, it was an excellent talk. And how to handle, how to go with the adnexal structure vaginally so that this ureter injury and all that can be prevented, and how we can do that all procedures. It was really an excellent session. And small tips like how to prevent the granuloma formation vaginal granuloma. It was an excellent session.
Thank you, ma'am.
I thank all of you to invite me as a chairperson. Highly privileged.
Thank you, madam. Next, we move on to second session. I request Humayul to introduce the first chairperson, Dr. Poonam Belokar and Shweta Kolja.
Welcome, Dr. Poonam Belokar. She's a consultant from Amravati, secretary of her society, and she has won Mr. Tank Award, a reproductive health award, and she has also won Drushas Award from for the society, and she is the director of Belokar Hospital, Amravati, and she has a special interest in obstetrics. Welcome, Dr. Poonam.
Bhumiyal ma'am, please unmute ma'am.
Oh, I'm sorry.
Thank you. Thank you, madam. Thank you.
Actually, welcome, Dr. Shweta, and she's standing for the chairperson she's the director of Niramai Care Women's Center, Indore, and she is the vice president of Indore Obstetric and Gynaecological Society, and managing committee of ISAR, and she's also the librarian of MP ISAR, and managing committee member of MP IAG, executive and convener in the infertility committee. I'm AMPOGS, and she's also the coordinator of Foxy Committee Wildlife, midlife and infertility onwards. She's got plenty of awards to her credit, so welcome, Shweta.
I request Sujit to introduce Suhasini Bhopi madam and Narendra Jope sir.
Yeah, I would like to introduce and welcome Dr. Suhasini Bhopi ma'am. She is MBBS MD Obujay from GMC Aurangabad. She director of Varad Netralaya and Maternity Home, Pusat, District Yavatmal. She is in private practice since last 20 years, president of Pusat Ubujay Society. Welcome, Dr. Suhasini. Then I would like to introduce and welcome Dr. Narendra Jope. She is MBBS MD Obujay, MBBS from Bhausaheb Bhire Medical College, Dhule, MD from GMC Nagpur. He has done ICMR genetics course from SGPGI Lucknow. He is having special interest in fetal medicine and laparoscopy. He is practicing as consultant gynecologist at Navjeevan Hospital, Chalisgaon from last 15 years. Welcome, Dr. Narendra Jope, sir.
Now I request Poonam. Poonam Belokar to introduce our second second topic speaker, Dr. Tapasi Pati madam. Poonam madam, are you there?
Yes, ma'am. Yes. Thank you, respected madam. First of all, I would like to thank Dr. Radha Lakshmi madam and Dr. Sujit sir to make me this part of this webinar. Now moving towards Dr. Tapsi ma'am. Dr. Tapsi madam is a professor HOD of IMS and some hospital campus too. She is a secretary of Bhubaneswar OBGY Society, member of ISOPAP, IAG, IMS and SOFC, published 17 papers and 2 book chapters, national trainer in contraception and family planning. So moving towards her lecture. Thank you, ma'am.
Thank you, madam.
Tapasi madam.
Thank you for your
good evening, madam.
Good evening, everyone. At the outset, I would like to thank Dr. Radha Lakshmi ma'am for giving me this opportunity, and also Bhagya Lakshmi ma'am. And I also thankful to my chairperson. And today I am really blessed to talk in front of the Guru of Guru and my own Guru, Dr. P.C. Mahapatra sir. And I know I am really spellbound to have this podium because I am in front of Janmejaya sir, P.C. Mahapatra sir, and other stalwarts present here. My topic is adnexal mass. Please let me share the topic, share my slides. So this adnexal mass is a very vast topic. When we know
what are the type of mass, we know what to do. My guru has told me it's very easy to do things, but we are trained in our PG to know what not to do. So today I will be focusing what not to do. Adnexal mass, why we are discussing adnexal mass? Because nearly in, day out, we encounter this thing. And we bother about the things when it is basically large mass, postmenopausal mass, and there is a chance of malignancy which we are afraid of. We want to give maximum facility to our, or maximum benefit to our patients. So where is the dilemma? Dilemma is in diagnosis, and once we diagnose, we know what to do. So why we bother? Because adnexal tumors are most difficult to diagnose, most confusing tumors. They pose therapeutic dilemma also, whether to treat, not to treat, when to treat, young girl, whether to go for oophorectomy or not. So there are so many dilemmas. And most tumors of ovary we know are benign. But the very small portion which is malignant, we are bothered about that. And malignant tumors of ovary are diagnosed very late. That's why they are most lethal. They are otherwise known as silent killer. So coming over to epidemiology, 75% of ovarian tumors are benign. But this 21% malignancy is the bothersome. 4% are of low malignant potential, where we are again confused. What to do? We have to follow, when to intervene. Then comes 75% of ovarian masses are in premenopausal women, but 75% of postmenopausal adnexal masses are again malignant. So risk factors we know, if she has a family history of breast, ovarian or colon cancer, if she has 2 or more relatives with ovarian cancer, breast cancer before age of menopause 50, and multiple exposure to ovulation induction or hospital medicines or BRCA1 and BRCA2 mutant.
শুনছি মানে জাস্ট লগ ইন করে নিলাম যাচ্ছে নিচে যায় গেল
20% are diagnosed with
খালি লগ ইন করে দিয়েছে ওখানে নোট হয়ে যাচ্ছে হ্যাঁ করেছিল সব
Madam, Madam, 1 minute, 1 minute, madam, please.
Surgery.
Sahiti, mute all.
Undergo surgery. Pardon me, ma'am.
Sahiti, mute all except the speaker.
Okay. And 13 to 20% of these masses come out to be malignant. The most common differential diagnosis in reproductive age group, we have to think of ectopic. We have to be ectopic minded to diagnose ectopic. Endometrioma is another common diagnosis nowadays. And we should not forget genital tuberculosis, which may give rise to tumors. But in postmenopause, any ovarian tumor or any adnexal mass, any in postmenopausal age group, we have to first rule out malignancy. So coming over to details of differential diagnosis, we know like functional cyst, hemorrhagic cyst, endometrioma, dermoid cyst, serous or mucinous cyst, malignant tumors like germ cell tumor, epithelial tumor, tubal pathologies like hydrosalpinx, hematosalpinx, tubovarian abscess, and there may be uterine-related adnexal masses, which may be pedunculated subserosal fibroid or broad ligament fibroid.
Sahiti, can you mute those 2 persons?
Other organs inside ovary.
Arpita and something else.
Appendiceal abscess, there may be a diverticular abscess, colonic carcinoma, urinary tract distended bladder is sometimes diagnosed as ovarian cyst and all. Pelvic kidney and retroperitoneal masses like lymphadenopathy or lymph node tumors, nerve sheath tumors, or peritoneal inclusion cysts. How to diagnose? Of course, from history, we know age, And we should not forget about missed period. We should not forget about pregnancy. Pregnancy has to be ruled out in reproductive age group. And clinical features, we know signs, symptoms, bilaterality, size, fixity, consistency, all these things gives us some way to differentiate. We depend upon mostly ultrasound. MRI, CT, PET scan, though they are available, they are not first choice of modality for investigation. We also go for markers like CA125, SCG, CA, AFP, HE4, etc. And we all know these are used for CA125, basically surveillance and stratification, and they are primarily used for epithelial ovarian carcinoma. Similarly, SCG for differential diagnosis, gestational trophoblastic disease, CA for mucinous tumors, also rule out GI origin. AP, yolk cell tumor, abdominal carcinoma, and HE4 epithelial ovarian cancer. So, what is the best modality for diagnosis? We are using transvaginal ultrasonogram for most of the things, but abdominal has its own role. What are the advantages of TVS? It is fast line imaging for all adnexal masses, but large masses we should go for TS. So in my opinion, we should first go for TS and then for TVS. It allows assessment of morphology, vascularity, mobility. It enables for pattern oral scoring, and sensitivity and specificity is good in case of TVS. Other imaging modalities are MRI, CT, they are used as second-line modalities of investigation. MRI is usually used to know tissue extent of the lesion, and there is no radiation exposure. CT primarily used for staging the malignancies. It is not used as initial mode of diagnosis. PET CT has a limited role, maybe very less in adnexal masses. In pelvic ultrasound, we go for ovarian morphology, size, volume, consistency, number of locules, wall thickness, and presence and thickness of septum. Trans-abdominal ultrasound, what we do, it gives a global view, then it gives a relationship of the mass to the organ. Large masses can be evaluated by trans-abdominal ultrasound. Extrapelvic extension and evaluation can be done, but what is the disadvantage? It is low frequency transducer, and full bladder is a requirement for the trans-abdominal space. Now, with ultrasound, we can get a panoramic visualization which gives better assessment of the entire adnexa and its relationship to the uterus and other pelvic structures. Though TVS has better resolution, better Doppler studies, easier scheduling, and they avoid also abdominal scars. They can be used in obese patients, which is a hindrance in trans-abdominal scan, and rotators. Doppler is another required mode where it confirms or excludes a lesion, assign an anatomical diagnosis, assess extent and contralateral adnexa, look for borderline tumors, remember the corpus luteum while doing a transabdominal ultrasound and Doppler, and assess the entire abdomen, so also pleura on either side while doing a scan for malignancy. Now we are using colored spectral Doppler, where we can find tumor neovascularization. Neovascularization is identified by dilated saccular and tortuous vessel, elongation and coiling, dichotomous branching, and no decrease in diameter of higher order branches. There is irregular distribution of blood vessels, vessel with irregular diameter, low resistance index, and tumor legs are seen in case of spectral and Doppler. In power Doppler, we have enhanced sensitivity to low velocity flow, and assessment of tumor vascularity is better. We calculate for BI, FI, BFI. BI is vascularization index, which indicates vessel density, ratio of collar vessels and total vessels within the volume of interest, where BI is higher, more vessels are present. When it is more than 3 to 5%, then we think of malignancy. Flow index, again, it reflects blood flow intensity, ratio of total color signal intensity to the number of color vessels. Higher Fi shows greater flow within detected vessels. Vascularization flow index, again, combines vessel present and its flow. Ratio of total color signal intensity to all vessels within the volume shows the BFI. Higher BFI shows enhanced vascularity and perfusion. So coming over to certain studies, what they say. This is a study in 2023 where they studied for role of three-dimensional power Doppler for detecting ovarian cancer in adnexal masses, a systematic review and meta-analysis. They found overall 3D Doppler, 3D power Doppler, vascular tree assessment pooled sensitivity as 77% and specificity as 80%. Pooled sensitivity specificity of 3D PD vascular tree as per studies, including only complex and suspicious masses, were 90% and 88% respectively. So they concluded the diagnostic performance of 3D PD for discriminating benign from malignant adnexal masses was good. This is another study which was published in 2024, where it was a three-dimensional ultrasound, where they found that three-dimensional ultrasound is a valuable diagnostic tool for patients with ovarian malignancy. The result was the pooled sensitivity and specificity was 0.89 and 0.94 respectively. They concluded 3D ultrasound and 3D PD are proper diagnostic tools for ovarian cancer. So how to know the organ of origin? We know sliding sign, beat sign and rim sign. So beat sign, the mass originates from the organ it deforms, where the organ is shown as a beat around the mass. It helps differentiate between intrinsic and extrinsic masses. Hyperechoic and vascular rim around the cyst or mass, which may be suggestive of malignancy or inflammatory, is seen in rim sign. So when we say about functional cyst can be follicular cyst, corpus luteum cyst or theca lutein cyst. Follicular cysts are usually anechoic, thin wall and unilocular, less than 3 cm in size. Corpus luteum, thick wall, peripheral vascularity present, and there may be possible hemorrhage inside the cyst. Theca lutein cysts are usually bilateral and multilocular. They are large, but it is asymptomatic and less than 5 to 6 cm in size. There is a spontaneous. So while treating adnexal mass, we should remember corpus luteum and we should think ectopic to rule out ectopic. Other masses, impacted tissues, bowel mass, enlarged neurovascular masses, retroperitoneal masses are also. Morphological division of the masses are done as non-septated clear cells, septated clear cells, cyst with internal echo, solid tumors, septated cyst with cystic solid component. So our suspicion increases as the division goes down. We characterize the masses as for IOTA scoring. IOTA group developed standardized terminology and description rules to improve pre-operative classification of the ovarian mass. So basically, it is a benign and malignant. Benign we know 1, 2, 3, 4, 5, and malignant again M1, M2, M3, M4, M5. We all know the IOTA simple rules, so I don't think I should go into more details of it. So when it is benign with B features, it is unilocular cyst, smooth multilocular, less than 10 cm, solid components less than 7 mm, presence of acoustic shadows, no detectable Doppler signal. In M, M1, M2, M3, M4, M5, irregular solid tumor, irregular multilocular solid cyst, more than 10 cm, more than 4 papillary structures, ascites, and high Doppler signal. Then in IOTA classification, when it is more than one M feature and no B feature, we take it as malignant. more than one B feature, no M feature, we take it as benign. When both the features are there or none are there, it becomes when both B and M features are not there, it becomes inconclusive. So mass type, unilocular, solid, multilocular, solid or solid. Cyst content, anechoic, low level echoes, ground glass appearance, hemorrhagic or mixed. Solid parts, papillary projections, wall irregularities, vascularities is scored 1 to 4, and other signs are considered as acoustic cytoge and ascites. And its sensitivity is 90%, specificity is 95%, which is comparable to expert subjective assessment. Now they have come out with a adnex model, which is used where we are using this chart, and with this chart we will be able to score the system, and this is a adnexal scoring model. ORADs we know, ovarian adnexal reporting and data system. So here also we score 1, 2, 3, 4, 5, and 0 is incomplete evaluation, where lesion and features are relevant for risk of stratification and cannot be accurately characterized due to technical factors. There we go for repeat ultrasound and MRI. 1 is normal ovary, nothing to be done. 2 is almost benign, where score is less than 1%. They are usually simple cyst, unilocular, non-simple cyst, smooth surface, and less than 3 to 10 centimeter. And depending upon the menopausal status, we take up the decision. 3 is low risk, where it is typically benign ovarian lesion, but unilocular or bilocular smooth walled cyst more than equals to 10 centimeter, or multilocular smooth cyst less than 10 centimeter. And in these cases, we do more of imaging and more of studies, and they have to be followed with ultrasound. 4, it is intermediate risk. Again, in these cases, imaging has to be done and this should be followed. 5 is high risk, where more than 50% chance of malignancy, and they should be referred to oncology department, oncogynecology department. And this is another system where gynecological imaging reporting system or data system is used. Again, same 0, 1, 2, 3, 4, 5. Here, definitive benign, where there is 0% chance of malignancy. Probably benign, adnexal lesion, thought to be functional. So then 1 to 4% chance where it is probably benign, probably malignant, 5 to 20% chance, and very probably malignant. So how we classify the adnexal masses? Generally, we say unilocular cyst without septa or solid component, unilocular solid cyst with a solid component, multilocular cyst at least one septum but no solid component, multilocular solid cyst, multilocular with solid component, and solid tumors. Again, coming over to the flow chart where adnexal masses can be cystic, can be solid or complex. Cystic, unilocular, no solid component, simple cystadenoma, simple cyst. Multilocular, few thin septicem's, cystadenoma, borderline inflammatory. They have to be followed. You cannot leave them. Solid, homogeneous fluid is there. We think of endometriosis or hydrocephalus. Heterogeneous, fibrous, we think of solid tumor. If benign, fibroma, thicoma. Complex, solid nodules, vegetations, thick septa, we think of carcinoma. Once we know what type of tumor it is, what type of mass it is, I don't think there is any hesitation taking up, because we are all good surgeons and we are doing it. So now Clinical approach, we have to exclude urgent conditions like ectopic, adnexal torsion, etc. Exclude malignancy, that is ovarian or fallopian cancer. And few patients who present with an adnexal mass will ultimately be diagnosed with malignancy. Anatomic locations, ovarian masses, they can be physiologic cysts with follicular or corpus luteum cyst, benign ovarian neoplasm, or ovarian malignancy. Major salpingeal masses can be paratubal or paraovarian mass, tubo-ovarian abscess, or broad ligament leiomyoma. In tubo-ovarian mass or tubal masses, we have to rule out tuberculosis, that we should not forget. Management according to the age, children or adolescent, adnexal torsion is more common in children. Germ cell tumors are common among young age. Majority of adnexal masses occur in reproductive age group. Most of these masses are benign. 80 to 85% benign adnexal masses are with reproductive, functional, pregnancy-related etiologies. Many of adnexal masses are associated with the menstrual cycle abnormality or hormonal effect. Ovarian fallopian tube cancer is less likely in premenopausal age group, whereas in postmenopausal age group, it is the most likely diagnosis. Excluding malignancy is the main priority in postmenopausal age group with an adnexal mass. Average age of diagnosis of ovarian cancer in United States is more than 50 years old. Urgent conditions like adnexal torsion, tubo-ovarian mass also occur in postmenopausal women, but are less common, but should not be forgotten. Low risk postmenopausal masses can be managed in general gynecology unit, but high risk cases should be sent to gynecologist. So coming over to conclusion of my topic, there is a diagnostic challenge. Overlapping features in benign and malignant lesions give us a challenge, especially complex premenopausal masses need advanced diagnostic procedures. High resolution transvaginal ultrasound with color or Doppler are required. Classification systems like IOTA, ORAS, GIRAS are required or should be followed. Tumor markers help us for diagnosis and in case of malignancy for follow-up also. Expectant management for simple cyst is the in thing. MRI is indeterminate. It is not used as a primary method of investigation, but once malignancy is diagnosed, it may help to know the extent. Referral to oncology in high-risk features and use of tools like RMI and ADNEX model for risk stratification should be used. So a systemic evidence-based approach combining clinical judgment and standardized imaging and biomarkers is essential for diagnosis of adnexal mass. Management must be tailored to the underlying etiology, respecting the factors such as age, fertility desire, and risk of malignancy and symptom of the patient. Individualization of care ensures both safety and optimal outcome. As I come from the place of Lord Jagannath, I say you, I bring you blessings from Lord Jagannath and thanks to all of you.
Thank you, Tapasi Madam, for your excellent lecture. And thank you so much for accepting our invitation to be the speaker of our second session. And now I request the opinion of Dr. Narendra Jopi, sir. Narendra, sir.
Yes. It was a very elaborative and detailed informative lecture about adnexal masses. Especially the diagnostic part was very well covered, and Madam told all the details, use of ultrasound and 3D power Doppler for and many advanced tools for diagnosis and differentiation of adnexal masses. It was a very informative lecture. Thank you.
Thank you, sir.
Thank you so much.
Now I request the opinion of Poonam Bolekar, madam. Poonam, madam.
Thank you, madam. Very nice and informative topic, ma'am. Explained by Dr. Tapsi, ma'am. Very well explained. Topic was very informative and with very useful take-home message. Thank you, madam. And all best wishes to all chairpersons. Best wish you, madam. All the best, ma'am.
Suhasini, madam, is there? Suhasini, madam.
She has not joined. I think there is problem with network.
Network
Okay.
is one.
Shweta.
Good evening, ma'am. Tapsi, ma'am, a very nice lecture. And the way you have delineated and told about all the indices, which is important for risk stratification, I think so that carries a good take-home message for routine gynecologist, because basically we have to make sure that we are not apprehending the patient with something serious, and at the same time we are not missing something which is malignant or serious for the patient. So I think so this risk stratification and history taking and where to do markers, all this acumen should be there. We can't be doing markers for everybody. So I think such CMEs and webinars are very important to understand the important points. Thanks a lot, madam, for accepting our invite and being here with all of us. Thank you very much. Thank you, Lakshmi madam, Umail madam, and I request on behalf of team to just support us also. Thank you, sir. Thank you, ma'am.
Tapse, madam, one question, one doubt. Where to do all these tests, madam? HE4, which is not available routinely. Which lab you suggest?
In our place, we are sending to Halimercy only.
Okay. So we are only doing CA 124.
Onco center. Now recently, our onco center is at Cuttack only. Bhagya Lakshmi madam is our main onco
Yes,
gynecologist.
my signal is not very good. But I think HE4 test is now available.
Madam, it is not. So which specific lab
I think
you
Dr.
suggest?
Lals and all, I think if you connect with Dr. Lals, they will actually help you do that. And it's not about only HE4. Once you do the HE4, then they will totally give you a Roma report. So which has a cutoff value, which is premenopausal and postmenopausal, and then but then again that will tell you only about the risk of malignancy. But the final answer is sometimes histopathology or frozen. If you are very lucky to have frozen, it is good. Otherwise, many times we do only a simple imprint. When you don't have a frozen, just to know whether it's malignancy or not, you can send a specimen from the OT table, and they will do a smear from that imprint cytology and can tell you whether there are malignant cells or not.
Okay. So the Foxy now initiated the ovarian cancer screening program, and to report the at least 5 cases from each center or each society. Like that, yeah, Girija Wag madam along with Sunita Tandalwarkar, they have initiated that program, madam. Ovarian cancer screening.
But then actually we have to be frank that we really don't have any perfect method for screening of ovarian cancer.
Yes, madam. Yes, madam. Yes, madam. Yes. We are only even IOTA scoring system is not available in all peripheries. Yes, madam. All the and Sujit has to tell about this IOTA.
Yeah, IOTA very nicely described by Tapsi ma'am. All the images were very nicely with Dopplers, and where those indices we are not very routinely used to use those indices. We use only PI in our fetal medicine, versatility index, but the flow index, VI and VFI, those are not in routine practice for us.
Umayan?
Yes, actually, we are basically, hello.
Yeah.
That was a very excellent talk, madam. I actually, early referral is what I always get an opinion whenever I have a doubt. MRI, I do for my patients. And most of the time, as you're saying, like a high degree of suspicion, and always have a person of expertise in case we find we find that there is an evidence of malignancy. We go and start clearing up the surgery. We extrapolate the surgery and make sure that we try to remove as much of tumor as possible, and also the biopsies of your nodes and Sampling at least we do. So, but it is not very often. Most of the time we know that it is malignant or whether it is benign by our regular investigation too. But your talk was really excellent, madam. And very
The big
useful.
problem is only when the patient is young and desirous of children.
Yes.
So that's
Yes,
the
madam. Yes, madam.
We are having nowadays even 20. I have a patient, 23-year-old unmarried, with a papillary projections in her ovarian thing, and size is 18 centimeters by 12 centimeters. And all her markers are negative, and I've sent her for an MRI. She'll be reporting soon. So we are seeing now young children with so many issues. See, married, finished the family, nearing 50, the management is very, very simple.
That's easy. Yes.
Yeah, when it comes
Actually,
to
yesterday only we had a case of a young girl, 21 years old, with germ cell tumor.
Yes, germ cell tumors are.
It was more than 300. So yesterday only we did the surgery. Now says okay, we are planning for oocyte preservation, and then she will go for chemo. Like that only.
Bhagyalakshmi madam, we want to refer the cases to you, madam.
Oh.
Because
how far from
yeah, madam. Bhubaneswar is nearer to AP only. So most of the districts of some districts of Andhra Pradesh are nearer to AP. Bhubaneswar, madam. They can come.
Yes, I think Vizag, Ichapuram, all those places are near Odisha.
Yes, madam.
Yes,
and we want the
welcome,
opinion of
welcome.
you.
Always, our place is open, and we are a government institute, so all the treatment is free here, including chemotherapy, and everything is free.
Okay. So whenever we diagnose in our setup any malignancy, we refer the cases to surgical oncologist, madam. And they do say staging laparotomy followed by radiotherapy and chemotherapy free of cost, because there is a program known as Arogyashri. Under the Arogyashri, it is most of the covered, madam.
Yes.
So, and in many of the government hospitals also.
Thank you so much, Umail and Radha Lakshmi and Dr. Sujit and everyone for making me a part. It was really educative. The NDVH talk was also very nice.
Yes,
I enjoyed.
So
Thank you so much and best wishes to all.
Thank you, madam.
Yes, Sweta. Yes, Sweta.
Thank you, ma'am.
Thank you, Tapasi madam.
Thank you.
Thank you, Sweta.
Thank
Thank you,
you,
Aditi
Tapasi.
madam. Thank you, Sujata Kumar.
Thank you, Tapasi also. Tapasi's talk was also very good.
I can see Arpita Gandhi madam is also logged in. Sujata madam is finally here. Sujata madam, good evening.
Sujata madam, thank you.
Good evening, ma'am. I was in between also.
Okay. Oh, sorry,
Yes,
I
was
saw you
listening
now.
throughout the session.
Okay.
And
thank you, Radha Lakshmi madam, for bringing
thank
us
you,
all
Arpita
together.
madam.
I saw
Thank you,
Arpita madam, good evening. So nice you have logged in. You are muted, madam.
Yeah. Arpita madam. Thank you, madam. Arpita madam.
Thank you,
Aditi
madam.
Thank you, ma'am.
Aditi, thank you for logging in.
Thank you for making me a part. All the best to all of you. All the best, Shweta. All the best, Contra sir.
Thank you.
All the
Thank
best,
you.
ma'am. And all the best, Radha ma'am.
Thank
And
you,
good
Aditi.
evening,
Thank
Bhagya ma'am. Ma'am,
Yes.
heartiest congratulations to Bhagya Lakshmi ma'am.
Yes.
Ha.
Bhagya Lakshmi madam deserves it.
Yeah.
Arpita madam, thank you. We all four of us need your support also. Madam is President Diogar. Thank you,
Arpita madam.
Thank you, Arpita
Tapsi madam, need blessings. Okay.